On this week's 51%, we recognize Breast Cancer Awareness Month and sit down with Dr. Lisa Curcio of Nuvance Health to learn how to manage our risks, identify symptoms early, and navigate treatment.
We know that when breast cancer is diagnosed localized, that means it's just in the breast, that the cure rate is 95 to 99% if we just diagnose it early enough.
I'm Jessie King. It's all up next on 51%.
I was standing around like one of those girls I had seen in a movie. The whole world was a movie back then. I had my sunglasses on, I wanted to be seen without seeing shy Lolita. I wasn't really in it, I didn't really get it.
You're listening to 51%, a WAMC production dedicated to women's issues and experiences. Thanks for tuning in. I'm Jessie King. October is Breast Cancer Awareness Month. It's a time for women to share their stories and encourage others to keep a close eye on their health. And really, I think most of us have been touched by breast cancer in some way, whether we've fought it ourselves or alongside a loved one. The National Cancer Institute says breast cancer is the second most common cancer in women after skin cancer, but if you catch it early, it can also be one of the most treatable. So as someone trying to learn more myself, let's take a look at what we need to know here, before, during, and after a potential diagnosis. Our main guest today is Dr. Lisa Curcio. Dr. Curcio is the director of breast surgery at Northern Dutchess Hospital, part of Nuvance Health, located in Rhinebeck, New York. She herself successfully battled breast cancer at age 37, a devastatingly young age for a diagnosis, as most doctors don't even recommend women starting screening for mammograms until their 40s. Dr. Curcio says the number one cause of breast cancer is simply being a woman with breasts. She says the average woman has a 12 to 14% risk of developing breast cancer in their lifetime, but there are certain factors that can add on to that risk or raise someone's odds of developing it at a younger age.
You know, we always look at risk factors as modifiable and non-modifiable. The younger a woman starts having her menstrual cycle, it actually is a risk factor for breast cancer. For instance, up till about 10 years ago, the average age that a woman started having her menstrual cycle was somewhere around 12, 13. But it seems like over the past decade or so, we're seeing, women start having their menstrual cycles at 9, 10, and that's a risk factor. Also, having the stoppage of their menstrual cycles, which is menopause, at a later age is a risk factor. The whole thought process behind that is that the longer a woman's breast is exposed to her own endogenous hormones, the higher the risk. So if you have late onset periods and early onset menopause, that's actually protective for breast cancer. But we don't have much control over that, so we would consider that a non-modifiable risk factor. Other non-modifiable risk factors are family history. We can't choose the family we're born to. And if we have, for instance, multiple family members that have had breast or ovarian cancer, which can be linked with breast cancer, that is a risk factor. And it's a higher risk factor if, for instance, the age of onset of the breast cancer is younger. Like, for instance, if you have a mom who had premenopausal breast cancer, say in her early 40s, that's a higher risk factor than if you had a mother who was diagnosed in her late 70s. So younger age of onset, multiple relatives on the same side of the family. Also, if there is a history of bilateral breast cancer, that's a risk factor, obviously for breast cancer. Mm-hmm. But luckily, there are some modifiable risk factors. For instance, exposure to exogenous hormones. Certainly, 20, 30 years ago, the birth control pills that we used were higher dose estrogen, so that was a risk factor. I think a lot of the current day birth control pills are lower estrogen and not as high a risk. But really, the exogenous hormones that we see that are most associated with breast cancer risk would be exogenous hormones after menopause, so hormone replacement therapy. So we know that women who go on hormonal replacement therapy for over 7 years have a 30% higher risk of going on to develop breast cancer. So short-term use is okay, but certainly long-term use can be associated with an increased risk for breast cancer. The age that we have our first child is a risk factor. And so that's somewhat modifiable. First live birth after the age 35 is a risk factor for breast cancer, or not ever having had children is a risk factor. And then the last three things that I think are modifiable risk factors are weight. We know that obesity is associated with an increased risk for breast cancer, and activity level. Being more sedentary is a risk factor for breast cancer, and daily alcohol use. One drink a day increases breast cancer risk 10%. 3 drinks a day can increase the risk as high as 30%.
Well, thank you, I guess, for that rundown and that clarification. Because, I mean, it's something that's certainly been on my mind. I've been thinking about it more and more. I mean, most of us have been impacted by breast cancer in some way, but a number of women in my family have either been diagnosed or had close calls in the past few years. Like, my mom had a precancerous tumor that she had removed. My grandmother was diagnosed and successfully battled it, and my second cousin was diagnosed and successfully battled it. And it kind of just makes you wonder, like, where you're headed, you know?
I think the most significant factor looking at your family is like, how old was your second cousin that was diagnosed with breast cancer?
I believe she was in her 40s. My mom was in her 50s. My grandmother was in her 80s, actually. But my second cousin was on the younger side. She was in her 40s.
And the other thing that you want to do is ask that second degree cousin if she's had genetic testing, because usually when young women are diagnosed, we strongly recommend genetic testing to see if there is any genetic mutation that might be traveling in your family to increase your risk.
All right. And so, in the event that you're diagnosed with breast cancer, are there different types? How do we categorize it exactly? And are there variations that are more difficult to fight than others?
There are lots of different types of breast cancer, but in very general terms, there are 2 major types, because there are 3 major elements in the breast. There are the lobules, which are the functional unit of the breast that actually makes the milk. Then there are the ducts, which are these long channels that are connected to the lobules that carry the milk from the lobules to the nipple for breastfeeding. And then there is the stroma, or the connective tissue around the ducts and the lobules. So when we're very young, all of that tissue is really dense. But as we get older, the stroma tissue becomes more fatty. And then as we go into menopause, the breast tissue kind of involutes or goes into like a hibernation state, so that in optimal circumstances, all the tissue becomes very fatty. So the 2 main types of breast cancer are the ductal and the lobule. So that where they actually originate in the breast units, whether it's in the milk forming unit or the milk transit unit. And the most common type of breast cancer is the ductal, and that's 75 to 80% of all breast cancer. The lobular cancer only accounts for about 10 to 15% of breast cancer. But lobular can sometimes present more difficultly in that it doesn't show up all the time on a mammogram or an ultrasound, and sometimes doesn't really form a mass, but infiltrates like with little legs into the normal tissue. So it takes longer for it to show up on imaging. So it's not unusual for lobular cancer to sometimes present at stage 2 or stage 3, even though you've been getting your mammograms, because it doesn't show up as a discrete mass in the breast tissue. It has to get to a larger size to cause some change on the mammogram.
So, what does treatment usually look like? Is it usually a surgical process, or is it more radiation and chemotherapy?
You know, we look at breast cancer as a disease that we treat multidisciplinary. So there are surgeons like myself and specialist breast surgical oncologists. And then there are radiation oncologists that deliver radiation. And then there are medical oncologists that deliver medication, whether that's chemotherapy or what we call endocrine therapy, which is a pill that sometimes patients take for 5 to 10 years after they're done with all the active breast cancer treatment, to continue to treat it and prevent future events. Surgery is usually always part of treatment of breast cancer, unless a patient is diagnosed with stage 4 breast cancer when they're initially diagnosed. And that means the cancer's already spread beyond the breast. Everyone else, surgery is always part of the treatment. So the goal of surgery is to take the tumor out and take out a few lymph nodes to determine whether or not the breast cancer spread to the lymph nodes. So as surgeons, we are local treaters of breast cancer, and we give information to make other decisions. If we treat a patient with a cancer with a mastectomy, and they have a very early breast cancer, sometimes they don't need radiation. Maybe they just go on a pill for 5 years. But there are patients, for instance, if they have a lumpectomy, with lumpectomy, we always recommend radiation therapy. So they get lumpectomy and radiation. If they have a very early breast cancer, they might go on the endocrine therapy, which is a pill they take for 5 years. Or if they have a more aggressive breast cancer, they might get chemotherapy, they might get lumpectomy, radiation, chemotherapy, and even endocrine therapy. It really depends on the stage which the patient presents, how big the tumor is, and whether or not the lymph nodes are involved, and then the personality of the tumor, how much treatment they actually need. There are patients with DCIS, which is the earliest stage of breast cancer, that just get treated with a mastectomy and need nothing else. But there are patients that have lumpectomy, surgery, radiation, chemotherapy, and go on anti-estrogen pills for 5 to 10 years.
Over the course of your career, have you seen the way that we fight breast cancer changing? Are there new technologies or options available for people who have to navigate treatment?
Absolutely. If you look back in the 60s and 70s, everyone got mastectomies. So there's been, obviously more emphasis on preserving the breast, keeping the breast intact, and doing breast conserving therapy. And over the past 2 decades, an increase also in learning what we call oncoplastic techniques, which are techniques to not only take the cancer out, but reconstruct the area where we've removed the cancer by moving tissue around so that we don't leave the breast deformed or misshapen. So that's called oncoplastic procedures. We're also living in an era of individualized or personalized medicine. It used to be that if a patient had a bigger tumor or positive lymph nodes or were younger, they would automatically get chemotherapy. And in this day and age, you could have a bigger tumor and not need chemotherapy. We actually send that tumor for genomic profiling, a genomic analysis of the tumor to determine whether or not there's any benefit to chemotherapy. So in the past, someone who had a tumor over a centimeter or had a positive lymph node would automatically get chemotherapy. And nowadays, we would send the tumor for that test. And if they came back with a low risk, they would not need chemotherapy. They would just go on to their endocrine therapy or their radiation, whatever their next treatment modality is. So we are really living in an era of personalized medicine where we're actually looking at that patient's individual tumor to determine if additional treatments are necessary.
So hopefully as you're going through treatment, like it's successful, you reach remission, what kind of care is involved at that point? What are the kind of things that you see people dealing with post-cancer?
So one of the biggest things that we can do is empower our patients to know what they need to do to prevent future cancers, especially if they had their breast cancer early. They have a whole lifetime to live for future events. So we teach them lifestyle things that they can modify. We monitor them closely for the first 2 to 3 years. And then after that, they usually go to yearly follow-up. But they're always going to be committed, hopefully, to routine yearly imaging and breast examination by someone like myself who's very familiar with a breast that's had both surgery and radiation therapy or mastectomy and reconstruction. But a lot of, survivors do have long-term side effects from their treatment. And so the goal is to try to address those side effects. As patients are living longer and longer, there's over 4 million breast cancer survivors currently. And every year we're adding to that number of breast cancer survivors. We have to start addressing the long-term side effects of our treatment. So some young women, sometimes they get put into menopause early, and they have a lot of the side effects of menopause at a very early age. We have to worry about their bone density because they're not necessarily candidates that can go on hormone replacement therapy. And we want to make sure that if we're pushing someone into an early menopause, that we're addressing all those issues that will keep the rest of their life healthy, whether it's their bones, their heart, their cardiovascular health. So we really want to focus on trying to minimize or addressing side effects from the treatment. In prior years, we would do more aggressive surgeries and patients would have things like lymphedema. Nowadays, a lot of that has been obviated because we don't remove 2/3 of the lymph nodes like we used to. We just remove a few lymph nodes. But in those patients that need lymph node removal, we want to address whether they're at risk for swelling of the arm, get them in to see physical therapists, and doing preventative exercises to prevent lymphedema or risk for infection in that arm.
You tipped me off for this next question, actually, because you mentioned the importance of breast examination in those years after treatment, and specifically how it helps to have things checked by a doctor who knows what to look out for. One of the basic screening tips I've heard is that we should be self-assessing our breasts. But, how do you know what to look for? How do you know what is normal and what you should have checked out?
That's a great question. I think the most important thing for women to do is become familiar with their breasts when we know everything's okay. Like, for instance, in my patients, after we get a clean mammogram and I examine their breast, I want them to know what's going on in their breast at that point in time, because everyone's breast is different. If you have dense breast, it can be very lumpy. It can be difficult to feel lumps or appreciate differences. And so the best way that a person can be proactive with their own self-examination is to get as comfortable as possible with their own breast exam. And what that means is doing a breast exam every month. The more you examine your breast, the more you're like, if you feel something, it's like, yeah, but that was there last month and it hasn't changed. And the last time I was in with the doctor, they said, that's okay. There's nothing to be concerned about there. So getting really familiar with your breast and then knowing if something is new from month to month or if there's some change. It's not always a palpable lump. Sometimes it's a puckering of the skin or an inversion of the nipple or a new symptom of nipple discharge. There are lots of things that can indicate something's going on, but you have to have that awareness of your breast and be looking at your breast, examining it in the mirror and examining it in the shower and also in a laying down position. Because in the shower, you can feel things that are very close to the skin, but then when you lay down, the breast flattens out somewhat, and then you could feel things that might be somewhat deeper in the breast.
Well, Dr. Curcio, thanks so much for joining us today. Is there anything that I'm missing that you'd like our listeners to know?
I think the most important thing is to get your mammograms. We're still seeing a huge number of people that haven't gotten back on their regular schedule after the COVID pandemic. And so getting your yearly mammograms is the one most important thing you can do for yourself or your family, urge your family members to do, because we know that when breast cancer is diagnosed localized, that means it's just in the breast, that the cure rate is 95 to 99%. So the cure rate is extremely high. Breast cancer is a disease, for the most part, that we can prevent a lot of the, those long-term side effects from chemotherapy or aggressive surgery if we just diagnose it early enough.
Dr. Lisa Curcio is the Director of Breast Surgery at Northern Dutchess Hospital with Nuvance Health in Rhinebeck, New York. Dr. Curcio, thanks again for taking the time.
No problem. Thank you, Jesse, for asking.
Again, according to the American College of Radiology and the Society of Breast Imaging, most women should begin scheduling annual mammogram appointments at age 40. But it recommends women take a breast cancer risk assessment at age 30 to determine if they might need screening earlier than that. Dr. Curcio says the National Cancer Institute has a popular quiz online that you can take to basically compare your family history and reproductive health history to that of the average person. That's at bcrisktool.cancer.gov. But just to note, it can't accurately predict risk for women carrying breast cancer-causing genetic mutations or those with a prior history of breast cancer. And of course, these are predictions we're talking about. Some women considered to be high risk may never develop breast cancer, while someone with a low risk very well might. That's why it's so important to stay on top of your mammograms if you're of age. But what is exactly happening during a mammogram? I'd like to take a closer look now at Dr. Wendy DeMartini. Dr. DeMartini is a professor of radiology and chief of the breast imaging division in the Department of Radiology at Stanford University School of Medicine. She also served as president of the Society of Breast Imaging from 2017 to 2018.
So the mammogram overall is a set of pictures of the breast tissue that's obtained using an X-ray, a very low-dose X-ray. And overall, a standard mammogram is 2 pictures of each breast, and for each of those, the woman is positioned in the mammogram machine, and there's a bit of compression applied to the breast tissue with a little paddle on one side. And that's really important to thin the breast tissue out so that we get an accurate look at the breast tissue and increase our likelihood of finding breast cancer when there.
Well, Dr. DeMartini, thanks for joining us. Are there any cases where someone might need more than a mammogram to accurately screen themselves for breast cancer? I've heard having dense breasts, like people usually do when they're younger, but even if you're older and you have dense breasts, that can make it more difficult. But why is that?
What we mean when we're talking about dense breasts is not the way, for instance, that the breasts feel. Breasts can sometimes feel sort of dense or firm due to a variety of normal things. But when we're talking about dense breasts, from a mammogram perspective, what we're talking about is due to the amount of what is called fibroglandular tissue and the amount of fat. We all have different proportions of the fibroglandular tissue relative to the fat, and the more fibroglandular tissue there is, the more dense the breast is. Overall, dense breast, that fibroglandular tissue looks relatively white on a mammogram, and cancers also look white on a mammogram. So the sensitivity or ability to find breast cancers is lower when women have denser breasts due to what we call a masking effect. A cancer could be there, but is masked by that adjacent fibroglandular tissue. The other thing is that breast density itself is a slight risk factor for developing breast cancer. So it's important to know about your breast density, and the majority of states now actually require some notification to patients when they have a mammogram about what their breast density is. And then once one knows about the breast density, and in particular, if you have denser breasts, then it's important to talk to your healthcare provider about whether some additional tests other than mammography added to mammography might be helpful in identifying breast cancer that the mammogram might not show. And there are a variety of different options, and those would include having a screening ultrasound or having sometimes a breast MRI that's a very short version of that. There are a number of options for women who have denser breasts for what would be considered supplemental screening, and I think the main next step is to talk to your referring provider about whether some additional testing might be appropriate for you. It is still very important, though, to still have the mammogram, even though mammography doesn't find all cancers and becomes less accurate or sensitive as the breasts get denser. It still finds most breast cancers overall and is a really important test, and the main test that we know reduces deaths from breast cancer.
The American College of Radiology and Society of Breast Imaging have updated their guidelines to recommend heightened screening for women of color and transgender women as well. Can you go into a bit about why they might need more screening or more attention?
There are a few factors. Number one, minority women are far more likely to develop cancer at younger ages and die from breast cancer at younger ages. And so, again, if we wait to identify their risk or we wait to screen them until, say, age 50, we're really losing the ability to identify breast cancer early in these patients. at a point when it is the most treatable. So really important. The message sometimes gets lost, and especially the fact that starting screening later disproportionately impacts the outcome of minority women. Mm-hmm. And then I think with respect to transgender patients, also not everyone realizes that transgender patients can benefit from screening, and there are some particular considerations about when and who, including whether hormones have been used and whether surgery has been performed. It can be complicated, but it's really important to have the conversations and make sure that transgender patients have conversations with their referring healthcare providers about when it's appropriate to be screened with mammography.
Is there a such thing as overdiagnosis? Like, is it possible to do too much screening?
Yeah, that is a great question. So overdiagnosis is this concept and a phenomenon that we have in medicine wherein some things that we diagnose would not have actually gone on to cause a health impact in a particular patient. And when we're talking about overdiagnosis of breast cancer, we're talking about diagnosing a cancer that would not have gone on to actually cause the death of a patient. But the risk of overdiagnosis overall is quite low. It's often been overstated, and there were studies that were done several years ago that really didn't have good study designs that really miscalculated the risk of overdiagnosis and overstated the risk of diagnosis. And overall, the only way you can completely avoid overdiagnosis is to not do any screening, and that means you do not have any of the benefits of screening. You're avoiding all of the life-saving benefits of screening mammography that we know if you don't do screening at all.
I guess lastly, is the technology that we use to detect breast cancer changing? Are there new methods and technologies that you feel can help us assess someone's risk earlier on or catch things early?
Yeah, so I think there's a number of things. First, the way that we do mammograms has definitely evolved. Historically, we used to do mammograms on a film, like old pictures that we used to take on film. Then we moved to digital mammograms. And now we've moved on to this newer option called digital breast tomosynthesis, which takes a set of very low-dose X-rays that get reconstructed into thin slices and allows us to kind of see around the tissue, and that also allows us to see breast cancer better. So the techniques continue to evolve in terms of how we're doing the mammogram. And then we now have the area of artificial intelligence, which has been applied to mammography in the past, but we're really in the new age in terms of the potential for artificial intelligence to help us interpret mammograms, both in terms of looking at a mammogram with the radiologist and helping the radiologist find cancer or exclude cancer, but also in terms of helping with the risk assessment. I think we're very much on the cusp of having things that we can use in the clinic for our patients that help us assess risk just using information from the mammogram alone in a way that's as good as these sort of more complicated risk assessment models. So we're really on the cusp, and I expect that our patients are going to be able to benefit from that in the next few years.
Dr. Wendy DeMartini is professor of radiology and the chief of the breast imaging division in the Department of Radiology at Stanford University School of Medicine. Dr. DeMartini, thanks for joining us.
Thank you. We really appreciate the opportunity.
Thanks for tuning in to this week's 51%. 51% is a national production of WAMC Northeast Public Radio. It's produced by me, Jesse King. Our executive producer is Dr. Alan Chartock, and our theme is Lolita by the Albany-based artist Girl Blue. A big thanks to Dr. Lisa Curcio and Dr. Wendy DeMartini for joining me this week. To learn more about the topics we discuss on this show, check us out at our website. That's WAMCpodcast.org. There we'll have episodes new and old and links to everything you need to know. Until next week, stay safe and schedule your mammograms. I'm Jesse King for 51%.
I was every single girl, I was nobody else, I was so sure of myself. I was 15 and a half, he was a hollow laugh. And I lost my cool somewhere along the way. At night and down the hallway, I had to learn how to look away. I lost my cool, no electricity, hot rain on the concrete, sweet melting little